Thank you for joining us today on the Anesthesia and Perioperative Medicine channel.
आज एनेस्थीसिया और पेरिऑपरेटिव मेडिसिन चैनल पर हमारे साथ जुड़ने के लिए धन्यवाद.
本日は麻酔手術器学チャンネルにご参加いただきありがとうございます。
Alright, let's get right into it. Today, we're talking about a subject that's becoming more and more critical for our specialty, our role in disaster medicine. I mean, just take a look at this picture. This was taken during Tropical Storm Allison back in 2001. That's a patient being evacuated on an escalator. This isn't your standard orderly transport from the OR to the PACU. This is what medicine looks like when the walls come down, literally. Disasters take everything we rely on, power, sterile environments, monitoring, supply chains, and just throw it out the window. It forces us to practice in these incredibly austere settings, and it really demands that we be at our most flexible and innovative.
And that really brings us to the core idea for today's discussion. In a disaster, the anesthesiologist is the Swiss Army knife. It's the perfect metaphor. When everything is chaotic and patients are flooding in, our unique skill set is what's needed most. We can manage an airway in the dark, resuscitate a patient with limited resources, manage complex critical care problems, and our deep knowledge of pharmacology is absolutely essential. We are the ones who can step into that chaos and create a pocket of stability.
So, to really dig into this, we're going to break it down into 4 main parts. First, we'll cover natural disasters. Then, we'll shift gears to look at acts of terrorism. After that, we'll get into the really technical stuff: chemical, biological, radiological, and nuclear incidents, or CBRN for short. And we'll wrap up with something that's on all of our minds these days: epidemic and pandemic outbreaks.
Okay, part 1, natural disasters. This is when nature itself completely overwhelms the systems we've built to protect ourselves, including our hospitals.
And each type of disaster brings its own unique set of problems. After the earthquake in Haiti, our colleagues who responded weren't just dealing with crush injuries and fractures. They were also facing infectious diseases they weren't used to, all in an environment with almost no resources. Then you have tornadoes. They're incredibly violent and fast, causing devastating trauma in minutes. But the danger doesn't stop there. Downstream, you get these horrific opportunistic infections like necrotizing mucormycosis that demand immediate, aggressive surgical debridement. And tsunamis. They are just brutal. The mortality-to-injury ratio is incredibly high, meaning more dead than injured, and they often wipe out the local doctors and nurses right when they're needed most.
But let's take a deeper look at hurricanes. So what are we talking about technically? It's a massive tropical storm where the sustained winds hit at least 74 miles per hour. But honestly, the wind is just the beginning. The real, lasting damage often comes from the storm surge and the widespread flooding that follows, which can completely cripple a region's infrastructure. And of course, the classic case study is Hurricane Katrina in 2005. The numbers are just mind-boggling. Over $100 billion in damage, 80% of New Orleans underwater. But here's the statistic that should really hit home for all of us. Look at the impact on our own workforce. In 2004, the year before Katrina, Louisiana graduated 24 anesthesiology residents. By 2007, just 2 years later, that number had plummeted to 13. A disaster doesn't just destroy buildings, it destroys the very fabric of a healthcare system. And recovering that human capital, well, that can take decades.
To give this some context, we use the Saffir-Simpson scale. We hear Category 3 or Category 5 on the news, but what does that actually mean for us? A Category 1 is bad enough, but once you get to a Category 4 or 5, we are talking about truly catastrophic damage. Buildings fail, infrastructure is gone, power, water, everything. An area can be uninhabitable for weeks or even months. Understanding this scale is crucial for us because it helps predict the kind of medical disaster we'll be walking into.
But here's a really interesting twist. Sometimes the biggest impact on your hospital isn't from the storm hitting you directly. So what happens when the disaster is 1,000 miles away, but it hits a critical weak point in our incredibly fragile medical supply chain? That's exactly what the entire U.S. healthcare system learned the hard way after Hurricane Maria hit Puerto Rico.
You see, Puerto Rico was a major manufacturing center for IV fluids. When Maria hit, production just stopped. And suddenly, hospitals all over the mainland were facing a critical shortage of basic crystalloids. This graph here is from the University of Nebraska Medical Center, nowhere near the storm. That red line is their weekly allocation of lactated ringers, about 910 bags. The bars show how much they were actually using. Week after week, they were right up against that limit, sometimes even going over. This wasn't just some minor inconvenience. It was a full-blown national crisis that threatened patient care.
And this is where anesthesiologists became the heroes of the story. At UNMC, our colleagues led the charge. Look at this timeline of their conservation strategies. On November 16th,
They changed flush protocols and pulled the small 250 milliliter bags. 5 days later, they standardized and restricted electrolyte boluses. But the big one, the real game changer, came on November 28th. They converted insulin infusions to syringe pumps and, this is key, mandated that all IV fluids in the operating room be given via an infusion pump. Think about that. Our department's expertise in precise fluid administration became a hospital-wide strategic asset. It's a perfect example of how our specific skills can have a massive impact far beyond the doors of the OR.
Now for part 2, acts of terrorism. This is a totally different beast. Unlike a hurricane that you can track for days, these events are sudden, they are violent, and they are intentionally designed to cause mass chaos.
The response on September 11th, especially at Bellevue Hospital, which was just a couple of miles from the World Trade Center, taught us some incredibly valuable, if painful, lessons. First, all communication systems failed. Phone lines, pagers, everything was down. They had to resort to using medical students as actual runners to carry messages. This led to a very simple but brilliant idea. Everyone wore big, clear labels with their name, title, and specialty. In the chaos, you had to know instantly who you were talking to. And look at their triage system. They specifically tasked senior anesthesiology residents with managing the yellow tag patients, the ones who were seriously injured and likely to need airway intervention. They put the experts right where they were needed most. And finally, they understood this was a marathon, not a sprint. Leadership mandated shifts to make sure people could rest and avoid burnout.
The scale of these modern events is just hard to comprehend. October 1st, 2017 in Las Vegas. In just 10 minutes of shooting from a single person, 58 people were killed and 851 were injured. Think about that number. 851 casualties flooding into emergency rooms all at once. It's a scenario that would overwhelm even the best prepared hospital system on the planet.
And behind these horrifying numbers are real people, including the responders. This quote from Dr. Devin Kearns, a pediatric anesthesiologist in Las Vegas, just sends it chill down your spine. He's at home on call expecting a routine pediatric case, and then he gets that call. There's been a mass shooting. In that single moment, his entire world, his entire professional focus changed. It's such a stark reminder that any one of us could get that call on any given night.
But it's not all grim. The response to the Boston Marathon bombing is actually a story of success, born from preparation. The IEDs they used created injuries you'd expect to see on a battlefield: shrapnel, blast injuries, traumatic amputations. But Boston was ready. For one, they had several level 1 trauma centers packed into a small area, which was a huge geographic advantage. But more importantly, the city and its hospitals took disaster drills seriously. They ran them regularly. So when the real event happened, the systems were in place. And it wasn't just physical practice. The staff, including anesthesiologists, had mentally rehearsed these scenarios. They had already thought through, what's my role in a mass casualty incident? That preparation, both physical and mental, is what saved lives that day.
All right, let's brace ourselves for part 3. We're heading into the deep end here, with chemical, biological, radiological, and nuclear incidents. These are the low-probability, high-consequence events that we all dread. And in this world, the number one rule changes. The top priority is no longer the patient, it's you. Provider safety comes first, because if we go down, we can't help anybody.
A CBRN event is never just a medical problem. It's a massive, multi-layered crisis. This graphic from the Department of Defense shows you just how complex it is. You've got local fire and EMS, state health departments, federal agencies like the FBI and FEMA, and sometimes even international partners all trying to coordinate. As clinicians on the ground, we have to understand that we're one piece of a much, much larger puzzle.
The 1995 sarin gas attack on the Tokyo subway was a terrifying wake-up call for the entire world. It taught us 5 critical lessons. First, it proved that military-grade chemical weapons were now in the hands of terrorists. Second, it showed that the standard hazmat training for first responders was totally inadequate. But lesson 3 is the most important for us. The failure to control the scene and decontaminate victims before they got to the hospital was catastrophic. It led to widespread secondary contamination of medical staff. At one hospital, almost a quarter of the staff became victims themselves just from treating the incoming patients.
So let's quickly review the agents. We can group them by how they work. You have the nerve agents, like sarin and VX. They're anticholinesterases, so they cause a massive cholinergic crisis. They basically short-circuit the nervous system. Then you have blister agents, or vesicants, like mustard gas. These cause horrible chemical burns, but their onset is delayed by hours. And finally, you have blood agents like cyanide, which are cellular asphyxiants. They stop your mitochondria from using oxygen.
Knowing these mechanisms is key to recognizing the toxidrome and starting the right treatment.
When patients start arriving, triage is everything. And for nerve agents, you have to know the difference between mild and severe symptoms. Mild exposure might look like allergies or a stomach bug, but severe exposure is dramatic and unmistakable. It's the classic sludge-M mnemonic: salivation, lacrimation, urination, defecation, GI upset, emesis, and meiosis, those pinpoint pupils. When you see that full-blown toxidrome, you know you're dealing with a life-threatening emergency that's going to lead to seizures and respiratory arrest.
Biological agents are a different kind of nightmare. The big challenge here is the delayed onset. A patient could be exposed and feel fine for days. Inhalational anthrax and pneumonic plague are incredibly lethal if you don't catch them early. But look at tularemia. With early diagnosis and antibiotics, the mortality rate drops from around 45% all the way down to 1%. That's huge. And then there's botulism. This is right in our wheelhouse. It causes a descending flaccid paralysis. These patients are going to need intubation and prolonged mechanical ventilation, and we're the ones who will be managing that.
So how do we protect ourselves? We have 4 levels of PPE. Level A is the full moon suit, totally encapsulated with its own air supply. Level D is just our regular scrubs, basically no protection at all. For those of us providing medical care in the warm zone, the area just outside the hot zone where decontamination happens, Level C is often the sweet spot. It gives you a chemical-resistant suit and a full-face respirator. It provides a very high level of protection from vapor and splash, but it's not as cumbersome as Level A, so you can actually perform procedures like starting an IV or even intubating. This all boils down to a few fundamental rules for survival. Rule 2, decontamination is non-negotiable, period. Rule 4, your safe zone, your hospital, must be locked down and protected from contaminated patients who just walk in off the street. But Rule 6 is the one we really need to burn into our brains. Decon, then treat. You decontaminate the casualty first, and only then do you start ACLS or ATLS. Trying to run a code on a contaminated patient is a recipe for creating more victims. But all of those rules are secondary to the one single most important rule of all. Rule number 1. Do not become a casualty yourself. Your knowledge, your skills, your calm leadership, that is the most valuable resource in this entire scenario. Protecting yourself isn't selfish, it's your absolute duty. Okay, on to our final section, and it's one we've all lived through recently: epidemic and pandemic outbreaks. This is the slow-motion disaster, the crisis that unfolds over months or years and tests the absolute limits of our healthcare system and our own personal resilience. The 2003 SARS outbreak was a major wake-up call, and this statistic right here should stop you in your tracks. 1 out of every 5 people who got SARS worldwide was a healthcare worker. That is just a staggering number. It was a direct result of not understanding the virus, not having the right PPE, and not recognizing how easily it was transmitted during aerosol-generating procedures, like intubation. It taught us a very hard lesson. In a pandemic, the hospital can become the most dangerous place to be.
SARS also gave us a very clear picture of risk based on age. As you can see in the table, the mortality rate was fairly low for younger people, but it climbed steeply with age. For those over 65, it was over 50%. This kind of data is absolutely vital. It helps us direct public health warnings, it helps us plan for ICU capacity, and, in the worst-case scenarios, it informs the heart-wrenching triage decisions we have to make when we're forced to operate under crisis standards of care.
When it comes to managing the sickest patients with the most dangerous pathogens, anesthesiologists intensivists are front and center. The Nebraska Bell Containment Unit is one of the premier facilities in the world for this. And when they treated 3 Ebola patients back in 2014, who do you think was leading the clinical care? It was our colleagues. It makes perfect sense. Managing a critically ill patient with multi-organ failure while wearing cumbersome PPE in a high-containment setting, that requires an expert in physiology, pharmacology, and procedural skills under extreme pressure. That is what we do.
So based on all these experiences, what are the core strategies we need to have in place? First, you have to know the enemy. Understand if it's droplet or airborne, because that determines your PPE. Second, training on how to properly don and doff PPE has to be standardized and practiced until it's muscle memory. Third, run high-fidelity simulations. Practice an intubation in full gear. Figure out the roles and communication before you have to do it for real. Fourth, be obsessive about aerosol mitigation. Use HEPA filters, negative pressure rooms, anything you can. And finally, don't forget psychological safety.
When people feel trained, prepared, and supported, they are far more willing and able to step up and do this incredibly difficult work.
So that brings us to our conclusion. We've looked at disasters caused by nature, by malice, and by disease. And the common thread through all of them is the need for us to lead, often far outside our comfort zone in the OR.
And we're back where we started, with the Swiss Army knife. It's not just a clever phrase, it's the truth. We are the undisputed experts in airway and resuscitation. Our training makes us natural leaders in the critical care environment. Our deep understanding of pharmacology is vital, whether it's treating a nerve agent or managing a drug shortage. And our ability to rapidly assess a patient's physiology and make a quick, decisive plan makes us incredibly effective triage officers.
So I'll just leave you with this one final thought. A disaster is coming. We don't know what it will be or when it will happen, but it will happen. We have the skills, we have the training, we have the temperament to be leaders in that moment. So the only question left to ask is the one you have to ask yourself. When that day comes, how are you going to step beyond the OR and lead? Thank you for your time.